you. So I've been asked to talk about surgical efficiency and complications, and so I decided to interpret the topic this way. And you'll see that I will talk first about how I started doing these complex surgeries and how I found them difficult and how the technique evolved with instrumentation. So basically I'll be discussing mainly subluxated IOLs today. And my interpretation of what makes surgical efficiency really is something that saves you time and also makes it much safer for the patient. And this should result with better outcomes for the patient. Okay, and this increase in surgical efficiency is really a result of better techniques and better instrumentation. So let's talk about the iris fixated IOL. Right, so let me just show you how we started in 2004. This was my surgery then. And you will see I only had a 27 gauge needle which I bent to levitate the IOL that was sinking into mid-vitreous. I had no other instruments to really control the lens position. I had a Coughlin hook in my other hand and brought the lens from the back to the front of the eye. And I had even a long needle there that supported the IOL so that I didn't need a third hand to help me to support the lens as I did the vitrectomy. And once I removed the support, I had to continue supporting the IOL, okay, as I completed the surgery. And then I put in the Kelman forceps through a widened paracentesis, and in that way I held the lens forward so that I could see the relief of the haptic against this dark, thick iris to allow me to place my suture appropriately. And I had a Coughlin hook in my hand to retrieve the sutures in the modified Seepser sliding knot. But really I felt that all this was not ideal. You can see the eye swinging around as this hook goes in each time, because the angulation of this hook was not meant for a suture. It was meant to actually push or pull the iris. And I got better at it. The eye moved less as I practiced this technique, but really it was not ideal. But we managed to do the surgery then and still give the patients reasonable outcomes. So this was in 2004 when we started. And then I thought, well, if only we had an instrument that could hold the IOL, it would give me so much better control. And that's when, together with ASICO, we designed the first IOL grasping forceps, something that would hold the lens without marking and destroying the lens. And also, I then designed a suture retrieving hook, which you can see is positioned differently than the Coughlin hook. So let's have a look at the surgery like this. Where is the lens? It's subluxated, it's held by some zonules, it's tilting to the mid-vitreous or even more posteriorly. I can't see exactly where the zonules intact are, so I use iris hooks to help me with that, with gentle indentation from a cotton bud. Everything comes to view, and you now see forceps being used to grasp the edge of the haptic with capsulorhexis forceps. Happens to be a Kawai forceps. And then I hold on to the optic this time. You can see the great control I have now. The surgery is so different. Okay, I have a pair of forceps. One is a 21 gauge, one is a 23 gauge. The 21 gauge holds the optic very well. And I don't need an extra pair of hands. I can hold up the IOL so that I can see the haptic seeing through the iris, and then I can do this maneuver with the suture retrieving hook without the eye rotating much. And I can even put it under low magnification because I don't really need to see, right? The hook just finds the suture. I don't get hyphema because it's really small and atraumatic and intended for this purpose. And then at the end, I create a peripheral iridectomy to equalize the pressure in front and behind the lens. All right, this prevents a reverse pupil block. So going on to a subluxated lens that is managed with a glued IOL that was popularized by Amar Agarwal and introduced to us by Gabor Shariath. So this is how I started. This is how Amar taught us as he popularized this technique for the cataract surgeon. So with a conjunctival peritomy having marked 180 degrees apart, this is a very important step for your centration of the IOL. We then create like a 3 by 4 kind of a trabeculectomy, limbal-based partial thickness scleral flap. Okay, I like to do it vertically because that's usually the shorter diameter for the eye, especially when you have many high myopes. Very important to have an AC maintainer, a 23 gauge maintainer here, right? So that the eye is pressurized and instruments can enter safely without detaching the choroid, okay, or having a choroidal infusion. And then you can see again with the forceps, one of them is a 23, one is a 21 gauge. You can handle the IOL and you can direct it to exactly where you want. And this is the time we retrieve the haptics, all right? Making sure we don't crimp it by ensuring that we grasp just the very tail end of the haptic. You can see even hand over hand, this was iris fixated and had actually come loose. We want to grasp just the very edge. But in this case here, I was not really using the appropriate forceps because I was just using whatever grasper I had that was borrowed from the visual retina service. And this is the glued lens technique that Amar popularized using a 26 gauge needle. We then create that track there and we tuck the haptic into the tunnel, right? And then we glue on the flaps. The glue is merely to make it much easier. The lens is not held by glue. So for glue to hold on and to be effective, we first need to make sure it's dry, and that's the reason for the air bubble in the anterior chamber. Once it's dry, we then apply the glue. All right, and then we use this glue to hold down the conjunctival peritomy. Right, in this way, everything is held in place, the lens is in good position, and then we replace the air bubble. Okay, and that's the end of the surgery. So I did this for several cases, and then I'll show you what happened. I had some issues with the glued IOL. I found that I had to dissect a lot of area, was a wide area of conjunctival dissection that made it surgically invasive, and I felt was really not that necessary. I had a case where I'll show you after this that the flap was glued onto the haptic, and therefore the chance that the flap may not adhere onto the scleral bag completely occurs, and that can lead to a wound leak. Right, the haptic length that's tucked in is also short, and the significant portion is actually just covered by the scleral flap and is held on by glue. Right, and the haptic can therefore slip. And if the haptic tip is crimped when you retrieve it from the vitreous cavity, it may not actually slip into the scleral tunnel, and it may even fragment, especially if you're retrieving an IOL from the vitreous cavity. And therefore, you may need to change the IOL when you had taken so much effort to strip off Somring's ring and the capsule bag. So this is a time when, together with ASICO, we developed two other instruments. One of them is actually for grasping the haptic horizontally, and one to receive it vertically. So these are 23 gauge instruments to go through the sclerotomy, and this is the way it's being used. All right, this is the vertical grasper, and this is the horizontal graspers. So let's have a look at this case here that I mentioned. I had a case that was a patient with Marfan syndrome. The sclera was very thin. The flap looked fine. It was dissected properly, and you can see me here gluing it into position. And I come on to this other side here. You'll see that this side, the flap is perhaps a bit thin, but that's what you have when you deal with the Marfans with the high myopia and connective tissue problems. And here I'm gluing it. I've still got air in the anterior chamber, and I exchanged that for the BSS. After the glue is supposed to have set in, I find that it's actually leaking on both sides. Okay? And in the end, I had to actually suture this down. The flap was thin, and I realized that what we were doing was just gluing onto a haptic. Okay? And sometimes, for that reason, it may not take very well. And this causes hypotony after surgery if we are not careful. So after this experience, I began to think about these glued lens flaps that we were creating. I had to do the same for the other side. You'll see here, I had to suture it as well. Okay, but of course, this is a special situation. It's a Marfan syndrome with very thin sclera. So as I thought about the problem, I decided that probably the best way to make it secure was when we have a side hinged flap, all right, and we will see it in this video here. This is an IOL that had subluxated onto the macula, and my vitreoretinal colleague had helped me to retrieve it. And so I created a side-based hinge so that the haptic would pass under this flap and be totally covered at all times. Okay, there was no chance of leakage. So here we are cutting the IOL out. With the help of all these forceps, it's really easy to remove them without dropping it into the vitreous cavity again. So you can see this is the vertical grooved forceps meant for this purpose. So that's the lucky 7 sign that Amar Agarwal described. And then we're going to transfer this haptic to the other forceps that is now horizontally positioned so that we don't crimp the haptic, because it's got a little groove within the tip of the forceps that doesn't crush the haptic. Okay? And because these are side-based hinge, you'll see that as the haptic traverses across into the tunnel, it's completely covered, right? And there's no chance for this to lead to any wound leakage. And you'll see that this flap is so much smaller than what I was creating with the original glued lens technique. So after a while, you can see these are the post-operative results. You can see the flap here is really very small. I decided, well, perhaps the way to go was really having no flap. And of course, we're all very familiar with Yamani's technique. Very, very clever technique that he has popularized and has been the excitement of many doctors who felt that this was really something they could easily do in the ORs to be in and out within 10 to 15 minutes of the case. So these are forceps here. I've got an angled forceps here that is meant for picking up IOLs that are vertically positioned in the vitreous cavity. And you can see just going 2 mm posterior to the limbus and then a 20 degree angle approach, sliding the conjunctiva. This is using a 30 gauge needle and threading in the haptics. You'll see that the IOL alignment is 90 degrees to what we prefer in the glued lens. Then we just leave it there, right? The needle is dangling in the vitreous cavity, plugged by the haptic. We do the same. It's much easier if you have a very big pupil when you do this technique, right? If not, you can put an iris hook there so that it enables you to see. And then simultaneously, you retrieve the needles, and then with a low temp cautery, you just create those little knobs there so that the flange will hold the haptic as it slides in and it does not go all the way in, all right? You can adjust the length to get the centration that you want. So this is a neat technique, but I'll show you what you need to get. Actually, the 30 gauge must be a thin wall or the dermatological needle, which is different from the standard one, and you can see the difference here. All right. The other important thing is that you should check that your haptic actually enters smoothly, because you don't want to be caught out when it's in the eye and the haptic does not actually match the bore of the needle. You could alternatively use a 27 gauge needle, right? And you again want to check that you make sure that the haptic enters the bore of the needle. The other important thing to have if you're going to implant an IOL is a 3-piece IOL with the haptics that are not made of PMMA but polyvinylidene fluoride, or PVDF for short. And the only lens that I know available is the Zeiss CT Lucia 202. All right, this is the lens here. And then you want low temperature cautery, not high temperature. And so the tips, what you want to do is that you want to have the position of the fixation here. You want to place your IOL perpendicular to it, right? And then when you pull your suture, your needle through, you want to have it 2 mm posterior to the limbus at a 20 degree angle approach, right? And about 2 mm posterior is the site where you enter the sclera. And the angle should be at a 5 degree angle to the iris plane. Okay? So I'll just show you this, and you can use it with a 27 gauge needle. I don't have hypotony with using a 27 gauge needle, which is the reason why Yamani has suggested a 30 gauge rather than a 27 gauge. Okay, you can still do this with a 27 gauge. You don't have to order those dermatological needles. They are rather expensive. They are meant for injection of Botox, right? You'll see how I retrieve the lens. All right, I use whatever instruments I have. You can grasp the capsule, you can grasp the optic, depending on how the case presents to you. All right, so this is a case where the bag is nice and clear without any Somring's ring. Sometimes we have to struggle with Somring's ring where the content may even be calcified. So I bring the the lens into the front of the eye, perpendicular to the axis of a final alignment. This is using 27 gauge needles. And that's with my glued lens forceps. Okay, I then thread it in to the bevel. And here I'm modifying it a little, just doing that creation of a flange so that it does not slip back as I introduce the needle and attach the haptic. It makes it a little more difficult. You will see that angle is a bit more difficult if you do it this way. But it makes it secure, all right? And again, it's important if you have a pupil that is large enough. Okay, so in this case here, you'll see this is well centered. So this case actually did very well. There was no post-op hypotony even with a 27 gauge needle. Now, my issue with this technique, and I've tried this many times, is that it's quick, but it may not always give you predictable outcomes. And being an ophthalmologist, I think we are all perfectionists. We like to see the optic being perfectly centered in the pupil. And so you'll see here, I was doing exactly what I thought was appropriate, marking, making sure I measured everything so that I would have a perfect lens centration. But you realize that even doing all this, we do actually pull on the IOL quite a bit, okay? And sometimes we may even kink the haptic, not the tip, but somewhere along here, its junction with the optic can be also kinked. And therefore, we can distort the shape of this three-piece IOL. Okay, so you'll see I got both needles now and I'm coming out. I thought, well, this is fine. It should be okay, but you can see the stress on the haptic here. Okay. But I was not happy with this because you can see here that I just can't get it perfectly aligned in the center. So I tried to adjust the length, which is what Yamani has taught us. I trimmed it a bit, shortened it a bit. I just can't get it perfect. So to prevent an optic capture, I said, okay, unless I redo everything, what I did was just to close up that pupil a little so that I won't get optic capture because the lens is not perfectly centered. Okay, so this was my frustration with the technique. I couldn't get it always perfect. Okay. And I'll show you this case here that after struggling, that was the very same case. Within a week, this IOL rotated. Okay. So I'm going to change the technique and I'm going to show you the technique which I have been doing now for, I've lost count of how many cases, but this is my current technique. So this is the IOL that I just showed you the surgery of. And it rotated because of the junction between the optic and the haptic had become loose. And so although the haptic looked like it's still attached, it's actually rotating within the optic. Okay? So now I have to have a third hand to help me because I can't optic capture this. And the haptic, one side is loose. So as I explant it, I hold on to that. And this one is the one that is loose. Okay, so you have to really cut this off first to explant it. And you see that this is the loose one that allowed the IOL to rotate. Okay, it's only then that I can explant it safely. So this is the technique which I've evolved to. No flap, just a slit, right? 1.5 mm posterior to the limbus, 2 mm width is what the dots show. It's the length of the slit. I hold on to the LL, always holding on. I've marked this 180 degrees apart, holding on to the tip. I hold on to this haptic and then I pull. So that gives me absolute control because I'm sure that I won't drop the LL. And here I am using the glute lens forceps that's got that little groove there that doesn't damage the tip to thread it in. So while this worked very well, you can see you can achieve the perfect centration. I just close the scleral tunnel and then the conjunctival peritomy. Okay, and you will see that actually you can recycle a PMMA lens with this technique, but not with the Yamani, right? So this is the lens that I retrieved from the back of the eye. With that groove there in the forceps, you can hold on to it and you can retrieve this. And you can also tuck it carefully into the tunnel, right? This is a fatter haptic. So I was just being very careful. I didn't want to break it because it would mean I have to really open up the eye 6 to 7 mm to explant this LL. So that's why I rotated it to make it easier to put it into the scleral tunnel. But you can recycle a PMMA LL with my technique, but not with the Yamani technique. So basically my technique is really very simple. You don't have any flaps, and this is just reduced to a slit. All right, it's a partial thickness slit. So this is 1.5 mm posterior to the limbus, and it's a 2 mm, I do 3 marks, all right? So it's a 2 mm width here, and what you do is really you go into the half scleral thickness, and as it comes out from the sclerotomy, that's the center where the sclerotomy is, a 23 gauge, you then have a 26 gauge needle, and you tuck this into the tunnel, all right? So this is really very simple, and it gives you very controllable, predictable outcomes. So it's just to show you another case here, a single piece acrylic lens which has actually dislocated just posteriorly, and I'm going to explant and exchange this LL. So what is important is that I do not put in the posterior retractor through the sclerostomy. All right, so it's a 23 gauge sclerostomy, but I do not expand the sclerostomy so I don't get hypotony. Right, I don't get any leakage of the fluid from the eye. Okay, so it doesn't matter how you inject the LL, but you align it parallel to the direction of implantation. Grasp the haptic end. Okay. Hold on to it as you pull it through. 26 gauge needle. Thread haptic in. And really there's no tension on this incision here. If you prefer not to close it, you can. But generally I prefer to have everything nicely sealed because you don't get any leakage of fluid from the eye. And you grasp just 1 mm posterior because you know that this is a 2 mm width that you have marked. So you have a perfect length and you know exactly where to grasp so that it does not crimp the haptic as you try to insert it. Okay, and as always, I do a little PI there to equalize the pressure between the front and the back of the LL. Let me show you a new instrument that's being launched in this meeting. So this is using a C2 Lucia, which today is my preferred LL for this technique. Okay. So this is just half scleral thickness, a 2 mm width, deeper on the side where you want to create the tunnel for tucking the haptic. So just 3 incisions, 1 for an AC maintainer, 2 for your instruments. It's picking up the LL. I use the angled forceps because it's more appropriate. It's easier to grasp the LL in this situation that's dangling. And then we strip off all the capsule remnants. Bring this lens forward. And at this stage, I very often ask for a bit of myostat to constrict the pupil a little, so that when you cut the IOL, you don't feel worried about dropping the IOL. You don't need a large pupil to do this. So you can see that at all times you are really in control because you're holding on to the IOL. I'm creating the PI now, cleaning up all the capsule remnants that might hinder appropriate positioning of your lens, and that's 23 gauge MVR sclerostomy being created in the center of the marks. And this is the CT loose here with the PVDF haptics. So you hold on to the haptics, glute lens forceps, horizontal one going in through the sclerostomy, holding on to it. You can see I'm holding on to it as I hold on to the other side, so you never let the haptic slip in. Hand over hand transfer, and then grasp just the very tip, hold on to both, pull it out. Okay, so now I'm going to show you this other instrument which is available in this meeting. So I usually, it came to this stage where I would struggle, but you'll see that this instrument is meant just for tucking in. It's got a little groove to hold on to the haptic. It's angled so that the forceps and your hand are not in the way. Okay, and it grips the haptic perfectly, and it's slim enough to go into this small little incision that you've created, and you can still see it. You can still see the haptic, so you can tuck it with ease. Okay, so this has made my surgery so much easier. And when I was doing a case last week, my nurse said, "Why didn't you invent this earlier?" Okay, because it's made life so much simpler. All right, and sometimes when we use other instruments that are not intended for this purpose, we end up crimping or breaking off the tip of the haptic, especially of lenses that we've retrieved from the vitreous cavity that have been in the eye for many years. So it has got a little groove there, you can see that, and it meets perfectly. It's just angulated, it's short enough so that even if you moved a bit, you don't have a great movement at the tip, and you have just that good control. You don't get crossing of the forceps. Okay, and I'll show you that even with a different IOL here, this is a J and JV AR40E, which is available in many parts of the world, but not the CT Lucia. So this is the lens that is also commonly used for implantation for intrascleral haptic fixation. You can also use this IOL with the forceps. It will grip well. Okay, so you grip just at the very tip along the groove, holding on to both. 26 gauge needle, and this also, you can see the tip there, right? You can see everything because this forceps is angulated so that it keeps the forceps away from that tunnel, and you can see exactly where you're threading it in. Okay, so this is really intended just for this purpose. So if it's not perfectly centered, because now we've made the pupil a little smaller, I use a Coughlin hook to retract so that I can see whether this is well centered. So just to show you, it can be done with the AR40E as well. So now I'll just show you the other IOL subluxations. And this is how I used to do it, all right? I used to use 10-O-proline, which I would definitely tell you it should not be used. You should use at the least 9-O-proline, because 10-O-proline would biodegrade after 5 to 7 years. And you see these IOLs subluxating again to the vitreous cavity. So this is what I used to do, all right? It's railroading, right, with a 10-O-proline straight needle, and I think many of you might still do this with a 9-O-proline, so one behind the haptic and one in front, so that the suture, when it's pulled through, which is double arm suture, will just actually loop around the haptic. So even with a single piece IOL, you don't need to explant this IOL. You can leave the bag on and you can merely suture this to center it, all right? So this is the Hoffman pocket. You retrieve the sutures through it, and then you tie a 3-1-1 knot to center the IOL. Okay? So this is done with just one paracentesis just opposite to the fixation point. Okay, so now what I'm going to show you now is how I prefer to do it today. All right, I prefer to use Goretex 7.0, it's called CV8. All right, this is off-label use for scleral fixation, but it's got a long history with pediatric surgery, and it's got excellent longevity. So let's have a look at a case which is similar. It's subluxated. It's a single-piece acrylic lens within the capsular bag. And this is the Goretex being threaded through a 26-gauge needle, starting from the bevel upwards. This is creating the Hoffman pocket, marking 180 degrees apart because I'm going to fixate both points, making sure it's symmetrical. And I'm now marking 1.75 mm posteriorly, 2 paracentesis, fill up with a bit of OVD, dispersive OVD. Now going behind the haptic, I then draw out the suture which I had prepared, and this becomes an extended loop, becomes a snare to draw out this other short segment of suture that I have here. Okay, this is the other end of the short suture that has got no needle. The reason why I use this is because the needle that comes with this particular suture is really not intended for ophthalmic use. It's a short, very thick needle. Okay, so this goes behind the haptic. You draw out the loop of suture, which when you introduce into the sclera bends on itself. Right, so this draws out one end of a free segment of suture, going on the other side. Okay, you extend that loop of suture that we introduced like a snare, and it then allows you to retrieve the other end of the suture and you draw it through. So in this way, you can then secure your RL and center it. So you retrieve the sutures from the Hoffman pocket on both sides. Same on the other side using a Sinski hook. So this is marked 1.75 mm posteriorly, and you can see the RL is well centered, and you tie with a 2-1-1 knot. Right, so you tie the 2 first to make sure the RL is centered before you finalize the knot. Okay, because the tension really decides on the final centration of your RL. So this is to show you exactly where you can find this. This has been published in the British Journal of Ophthalmology 2018. And this is to show you the various steps that I've described to you. All right, it uses a Goretex 7.0 26-gauge needle. You first thread the suture through the bevel. The tips are that the suture should be dry, your glove should be dry. And when you cut the needle, when you cut the suture, what you do is you cut it at an angle so that you have a sharp tapered tip of the suture that allows you to easily thread it through this needle. All right, and then you put on the insulin syringe that comes, and you use the hub of the syringe, insert it into the hub of the needle, and that makes sure that your suture does not slip. And then once you've bent it, okay, once you've bent it, you have the suture coming out here, and it's secured here. All right, when you introduce it to the eye, basically it doubles on itself, and that's how you create the loop. And what we do when we introduce it into the eye is we extend this loop. So this loop then becomes a snare and allows you to bring the suture that's attached to the capsular tension segment, for example, to the scleral fixation point. Or in the case of an RL fixation, it allows you to draw the suture from the external around the eye. All right, so you repeat that. Like what you see here, and you will see that the other end of the suture can then be retrieved to the scleral fixation point. So this is what I call the suture snare, and it's really very, very useful. So I'll show you its use when we want to use a capsular tension segment. So when would that be helpful, inserting a segment instead? So this is a patient who has a subluxating IOL, and it happens to be a toric lens. All right, and we want to preserve this lens because this patient has got high astigmatism. So this was done 6 years ago. I retrieved the IOL catching onto the capsule. I then suspend it, and I have already marked the axis that it should be attached to be fixated at. You can see the marks here, the toric marks with the alignment marks on the limbus. And again, we're using the same suture snare technique, bending it. Now we have a free segment of suture to the capsular tension segment. We're then going to use this snare to bring the suture ends through to the scleral fixation point. So that's a loop, and one end of the suture is going through. We've just retrieved one. We're repeating it for the other. And the other end of the short segment to the capsular tension segment is being retrieved to the scleral fixation point. Now you have both sides there, there's a loop around. You then retrieve the ends to the Hoffman pocket. You tie a 2-1-1 knot. The tension should be to center your IOL, and you'll see that you have this perfect alignment and the patient's vision is then restored. So I'm going to show you another case here. Where's the lens? Okay, so again, this patient I'm going to fixate, and I can do this positioning of the Hoffman pocket before I enter the eye because the eye is firm. I can do it because this is not a toric lens that I'm going to retrieve. I then prepare the suture snare, and you'll see it's done in seconds. I then prepare the capsular tension segment by preloading it with the Goretex suture, and you'll see this has flipped on itself. So this patient has got a subluxated IOL, has got a Sione 1L, which I'm now holding on to with the MSD forceps here. And then I'm grasping the capsular rim on the other side, and then getting support from iris hooks that have been positioned. Okay, so this has been fixated with a Goretex suture, this Sione 1L. And so this is just diametrically opposite. So I'm just making sure that the EDOF lens is centered before I position the capsular tension segment. And this is a lens that I want to preserve because the patient does graphic designs and he wants intermediate vision and he wants to have it back. Okay, I now transfer the hooks from the capsule to the iris so I can see exactly where I come through and I don't puncture the capsular bag. So this is the suture snare, which is used to retrieve this segment of suture. It's repeated for the other end of the suture. Okay, this is done in seconds. Okay, believe me, my friends, this is not difficult. It looks very complex, but once you get the hang of it, it's not that difficult. Okay? So I leave on those hooks there so that I'm sure I'm centered before I take them out. And then I'm looking at the pupil for some degree of guidance. You can use the Purkinje reflex to center your IOL. And this patient had his vision restored. Okay, so you'll see that in this case here, I used the angled grasping forceps because the IOL was really deep in the vitreous cavity. As you saw, I didn't see it right from the very start, and I had to indent it. Okay, so in summary, really having the optimized technique without the appropriate tools can lead to disappointing outcomes. Possessing the right tools makes surgery much easier, safer, and faster. And patients achieve better outcomes, and surgeons face challenging cases with greater confidence. So I encourage you to have a look at the instruments if you are into this kind of surgery, because this has changed my practice. Thank you very much. I'll be happy to entertain any questions you have. You've seen it all. Okay, very good. Thank you.